Hi everyone, welcome back. In this video, you're going to learn about the antibiotics that are going to fall in the penicillin class. Let's get started. All right, so here's what we're going to cover in this video. We're going to start with a review of the antibiotic classes. Then we're going to talk a little bit about the cell wall because these drugs are cell wall inhibitors. Then I'm going to go through each of these 4 penicillin classes. This is the main part of our talk. And at the end, we have a summary table. Let's go. All right, so let's start with a big picture look at the different targets of antibiotics. This is a screenshot from my video on antibiotics, and at the end I explained how most antibiotics can be categorized based on their mechanism of action of where they target the bacteria into one of 4 categories. We have the ones that inhibit the cell wall, the ones that inhibit the cell membrane, the ones that inhibit bacterial ribosomes, and then finally the ones that damage bacterial DNA and RNA. And in this video, we're going to be talking about penicillins right here. So these are examples of beta-lactams, which are cell wall inhibitors. So that's going to be our focus in the rest of this video. All right, so since penicillins are cell wall inhibitors, let's start with a quick basic science review of the bacterial cell wall. So most bacteria have a cell wall. It's important for preventing them from getting lysed. Eukaryotic cells don't have or need it because we have cholesterol in our membrane. Therefore, this makes this a very good target as an antibiotic because it's critical and specific to bacteria. The cell wall is made up of something known as peptidoglycan. Let's divide this word down the middle like this. The second part is glycan, which is carbohydrates. That tells you that the backbone of this wall is a carbohydrate or disaccharide repeat. The disaccharides are NAM and NAG, and this is what they stand for down here. So if you take a look on this picture, you can see that these are NAM and NAG disaccharide repeats up here and down here. You'll also see that there's something coming off of each of these repeats, and that's the peptide portion of the peptidoglycan. So these are short peptide chains of 5 amino acids, and they end with 2 dealanines. So diala down here, diala up here. What's important about this is that these peptide chains need to be cross-linked with each other so that the wall can be strong, otherwise the wall would fall apart. And the enzyme that does this cross-linking is known as transpeptidase, and that's this gray enzyme right here. And the way it does this is it binds these 2 dealanine residues. So it binds diala, super high yield, and by doing so, it causes cross-linking and strengthening of the chain. Final point here is that the other name for transpeptidase is penicillin binding protein. You can see it listed right here, and the reason is because this is the protein that penicillin binds to and inhibits, and that's how it leads to its actions, as we're going to learn. All right, so that was the cell wall. Let's see how cell wall inhibitors work. This is the mechanism of action of all the drugs that are beta-lactam cell wall inhibitors. So the reason they're called beta-lactams is because their chemical structure has a beta-lactam ring. What's important about this ring is that it mimics the diala. Therefore, it's going to bind to that transpeptidase, and by binding to it, it's going to inhibit it. So there's going to be no cross-linking of those peptide chain. Therefore, it's going to weaken the cell wall, and it's going to lead to bacterial lysis and bacterial death. And you can see how over here that's going to happen. So this is our transpeptidase, aka penicillin binding protein in number 3. It wants to come over here and cross-link this next one. However, it's going to get bound up by penicillin, which is this little orange thing right here. So because penicillin mimics diala, it's going to get into the binding site. It's going to prevent transpeptidase from coming over here and cross-linking. Therefore, the rest of this wall is going to be uncross-linked, it's going to become weak, and the bacteria is going to lyse and die. All right, so now that we know what beta-lactams do, let's talk about the drugs. There are 4 major categories. There's the penicillin class, cephalosporins, monobactams, and carbapenems, and these are all going to be very chemically similar. So there's penicillin up here and cephalosporin here. You can see that they're very similar, just a slight difference in part of their side chains. And these slight chemical structures is going to give them some differences in the spectrum of their antibiotic activity and their effectiveness against different bacteria, but they're all going to work through the same mechanism, which is that they all have the beta-lactam ring that's going to weaken the cell wall by the mechanism I talked about on the last slide. Now, in subsequent videos, I'm going to cover cephalosporins, monobactams, and carbapenem. In this video, we're just going to focus on the first category, which was the penicillin class, and that's penicillin and its derivatives. So the main drugs in this category are penicillin itself, amino-penicillins, the extended spectrum penicillins, and then the anti-staph penicillins. And I'm going to go through these one at a time, starting with penicillin number 1. All right, so penicillin is the OG because it was the first antibiotic that was discovered by Alexander Fleming. The 2 common drugs are penicillin VK, which is the oral, and penicillin G, which is the injection form. The way I remember is I just imagined that VK stands for very kind, and it's always very kind not to get a shot. So I remember that this is the oral one, whereas penicillin G is the one that's an injection or a shot. Main problem with penicillin is that it can't get to the cell wall of gram-negative bacteria because they have a protective outer membrane that surrounds that cell wall. Therefore, it's not effective against gram-negative bacteria, or at least most of them. And in addition to that, A lot of bacteria have developed resistance over time. So one thing that you're going to see over and over again when we talk about these beta-lactams is that many bacteria have developed an enzyme called beta-lactamases. And as you can tell from the name, these enzymes break down the beta-lactam ring. Therefore, by cleaving it, they become ineffective and can't affect their cell wall. And when we talk about beta-lactamases in the context of penicillin drugs, these are known as penicillinases. The other resistance of bacteria is that some of them have developed mutations in their transpeptidase or penicillin binding protein. Therefore, penicillin can't recognize and bind to it. So for the most part, the main two uses of penicillin that I use clinically are for treatment of strep throat, because this is caused by group A strep. So this is group A strep pharyngitis. And then the other one is for treatment of syphilis. And this may sound a little bit counterintuitive because syphilis is a gram-negative bacteria. And I mentioned up here that penicillin isn't effective against most gram-negative bacteria because of their outer membrane being protective. The thing that's unique about syphilis is that it actually has a pretty weak and fragile outer membrane, which allows penicillin to get through and affect the cell wall, and is actually pretty effective against treatment of most cases of syphilis. All right, so now let's talk about the next drugs, which are the amino-penicillins. And let's just pause here and think, why do we need a second category? Well, we just talked about the problem with the penicillins was that they're not effective against gram-negatives because they can't get past that outer membrane. So therefore, we want a separate category or a newer category that's going to help us get to our gram-negative bacteria, because it's very important to be able to have a way of treating those as well. So that's the point of these amino-penicillins, to broaden the spectrum, help us treat gram-negative bacteria. The two main common drugs here are amoxicillin and ampicillin. So a couple of mnemonics. Both of these start with AM, and AM stands for the fact that these are amino-penicillins. So you should remember that. And then amoxicillin, the one with the O, is the oral version, and therefore ampicillin is the injection version. And so as I mentioned, the way that they work is that there's an addition of the amino group next to the beta-lactam ring. Therefore, it's going to increase the spectrum of activity to more gram-positives and gram-negatives. And that's because this amino group is going to allow better uptake through the porin channels from the outer membrane. And therefore, the antibiotic is going to reach the cell wall of the gram-negative bacteria. Importantly, these are not effective against Pseudomonas, which is a very resistant gram-negative bacteria that I'm going to talk about shortly, but it's effective against most other gram-negatives. The main problem here is, again, these drugs are sensitive to the beta-lactamases that many bacteria produce that we talked about on the last slide. So to solve this problem, we can combine these antibiotics with other drugs known as beta-lactamase inhibitors. So here's how it works. We can give amoxicillin by itself and it can be effective. We can give ampicillin by itself and it can be effective. But if there is a bacteria that has beta-lactamase in it, if it's producing beta-lactamase, it may be resistant to these. In those scenarios, we would combine these drugs with these beta-lactamase inhibitors, which are clavulanic acid for amoxicillin and sulbactam for ampicillin. So when you combine amoxicillin with clavulanic acid, you get a medication called Augmentin, which you may have heard about. And of course, this is PO because amoxicillin was oral. And Augmentin stands for the fact that this augments the effect of amoxicillin. Similarly, if you combine ampicillin with a beta-lactamase inhibitor, which in this case is sulbactam, then you have a different drug called Unison, and this is an injection because ampicillin was injection. And therefore, again, we can use these drugs just on their own, but in cases where we're suspecting that the bacteria has beta-lactamase, then we would want to combine them to protect the drug from the actions of the beta-lactamase. The most common uses of these drugs is for infections that are involving anything in the head, neck, and respiratory tract, and that's because these are usually a mixture of gram-positives and gram-negatives, and that's what we can cover with these antibiotics. So things like sinus infections, otitis media, which is ear infection, pharyngitis, and animal bites, all of these are great examples of infections that we can typically treat with these aminopenicillins and sometimes combine them with the beta-lactamase inhibitors. All right, so now let's talk about the next category, which are the extended spectrum or anti-pseudomonal penicillins. So what makes these extended spectrum is that they're effective against Pseudomonas, which our prior class wasn't. There's only one drug here, which is piperacillin, and it's only injection, so there are no oral drugs in this category. The way they work is that these beta-lactams have an entirely different side chain that gives them the even wider spectrum. They cover two important things that we didn't cover adequately before, Pseudomonas and anaerobes. Their main limitation is just like the last case, they're sensitive to beta-lactamase bacteria. Therefore, we have to combine them with beta-lactamase inhibitors. So in this case, we combined piperacillin with tazobactam, which is the beta-lactamase inhibitor here. And this drug combined is known as Zosyn, and this is something that we use commonly in the hospital, especially in the critical care setting. So the main uses of this drug is going to be when you're suspecting Pseudomonas and anaerobes. So for example, pneumonia in a patient that has higher risk for Pseudomonas, like cystic fibrosis, this is a very high yield association. And then also intra-abdominal severe infections like abscesses, infections, and peritonitis. These are usually caused by GI bacteria that are usually have lots of gram-negative rods, Pseudomonas, and anaerobes, and therefore this is a good choice for treatment of these infections, especially if they're severe. All right, so let's switch gears. The final category here are the anti-Staph penicillins, and what makes these drugs unique is that they're resistant to the penicillinases that we've been talking about. Here are the common drugs: dicloxacillin, nafcillin, oxacillin, and methicillin. The one I've prescribed most commonly is dicloxacillin. And the way that these drugs work is that the beta-lactam ring has a bulky R group, so this is basically going to just get in the way, cause steric hindrance, and prevent access of the bacterial beta-lactamase, so it can't get to the beta-lactam ring, so it's going to protect it. So you can think of this bulky R group as a big burly security guard that's protecting our celebrity here, which is the beta-lactam, from the paparazzi, which are the beta-lactamases, so it's keeping it safe. The main limitation of these drugs is that they have very narrow spectrum. They only work against gram-positives, and that's because this bulky R group that we talked about is too big to get through the porins, therefore it can't get to the cell wall of gram-negative bacteria, and therefore it has no gram-negative coverage. And so the main indication or the main use of these drugs are for gram-positives, which are mainly staph and strep, and we commonly reserve these for infections by staph. That's because staph classically has a lot of beta-lactamase activity, and since these drugs are resistant to the beta-lactamases, they would be a good choice. And a mnemonic people usually use to remember this is NAF, as in nafcillin for staph. And a common indication that I've seen this used clinically by OBGYN and also us in the ER is for treatment of mastitis, which is an infection of the skin of the breast, usually associated with breastfeeding, caused by staph. Now, the problem with these drugs is that whenever we advance the drugs to target the bacteria can also then advance and mutate and create resistance. And that's what we have here. We have MRSA, so M stands for methicillin. So we have a form of Staph aureus that is methicillin resistant. And so what that means is that this type of bacteria, the MRSA, has actually mutated its transpeptidase. So by altering the penicillin binding protein, which is the drug target for beta-lactams, now that beta-lactams have less affinity, they can't bind as strongly, therefore they can't inhibit the cross-linking, and therefore MRSA is resistant to all the antibiotics in this category, as well as to all the beta-lactam antibiotics. So everything that we've talked about in this video and anything that falls in the beta-lactam category, MRSA is going to be resistant to it because it's altered the drug target, which is the transpeptidase. And therefore, in order to treat MRSA, we can't use any of these antibiotics. We have to use a non-beta-lactam cell wall inhibitor, such as vancomycin, or we have to use antibiotics with completely different mechanisms, such as the anti-folate antibiotics or the ones that inhibit bacterial ribosomes, and I'll cover those separately in a different video. But the point for here is that MRSA is going to be resistant to these antibiotics and all beta-lactams because their main mutation is altering the drug target, which is penicillin binding protein. All right, so here's a summary table of the 4 classes of penicillins that we talked about. So we have regular penicillins, then we have the amino-penicillins, the extended spectrum penicillins, and then finally the anti-staph penicillins down here. A couple of points here is to remember that all these 3 categories above are susceptible to penicillinases, so that's why we would combine these with the penicillinase inhibitors that I've added here to the side of the table. And then as far as adverse effects are concerned, all of these medications, all penicillins, can cause any of the hypersensitivity type reactions, so type 1 through 4. One thing not to forget about that I wanted to remind you is that autoimmune hemolytic anemia is a possible type 2 hypersensitivity reactions caused by penicillins. Don't forget, if you see on a test question an autoimmune hemolytic anemia, always look for potentially recent exposure to penicillins, because that could be an example of type 2 hypersensitivity leading to destruction of those red blood cells. And then the final point here is that while all antibiotics can cause C. diff, there seems to be a higher association with certain ones, and especially with amoxicillin when it's combined with clavulanic acid. So that's why I included that here. And then finally, sometimes patients who have pharyngitis caused by mono, which is the Epstein-Barr virus, if they're mistakenly given amoxicillin because it's thought that it was a bacterial infection, they can develop a classic rash. So this is known as the amoxicillin rash for mono, and that's an important association to keep in mind. Okay, that's it and that's all. If you want to learn more about this topic, you can check out the other videos that I've linked here. And if you guys enjoyed this video, please like, comment, and share it with others. And don't forget to subscribe to the channel so you don't miss out on upcoming content. But for now, thanks for watching, and I'll see you next time.